Let's cover an office procedure here and how to evaluate a statistic that is easily worth over $100,000. And what it is patient retention. How to evaluate your patient retention statistics. And this statistic routinely, it's typically a huge problem in chiropractic. Most chiropractors are really bad at keeping patients. I found a lot of them don't have a good model or they're not trained well. And when I do dropout analysis, in other words, I do a statistic to see where patients drop out, because that's what you want to do first. Then you can find the problem and then apply the solution. But it's one of the easiest ways to increase your income over $100,000, typically in 90 days. And the reason I say that is when I do practice analysis, almost always when I evaluate it, a third of the patients, when I evaluate chiropractors, a third of the patients are dropping out by the eighth visit. Well, that's a lot of money lost. That's a lot of revenue. Now, the patient retention model, what will determine patient retention, and what are the different business models? Well, the patient retention, there's two factors. There's two most important factors that'll determine patient retention. Number one is the doctor's conviction. How much does he even believe in what he's doing? Now, remember, most doctors are afraid to talk money. So that's where all the problem starts. They're afraid to talk money. They turn it over to somebody, like a staff member who's not even trained in it. And then they typically don't have a very specific business model. As an example, when I talk with doctors, I go, what's your patient education based on? They go, well, it's usually a combination of this or that or whatever. And so you get a hodgepodge, low conviction, and then number two is low confrontation. Those are and really I'd say three. So the very first problem is not having a clear model, not having a clear business model for patient retention. That's the first problem. The second problem is conviction, believing in it. And the third problem is confrontation, actually delivering it. So what are all the different business models when it comes to patient retention? Well, the worst model is market forces. So when you don't have a model, then you'll naturally get market forces. Well, what are market forces? Do patients get up in the morning, want to travel 22 minutes to a chiropractor, wait 15 or 20 minutes in his office, get treated for 15, 20 minutes, drive another 20 minutes back to the office or back to home and pay $50? Is that what they want to do 3 times a week? No. So you have to be able to overcome that, because we just naturally don't want to do that. We don't want to do that with anybody. We don't want to go to the optometrist. We don't want to go to the dentist. We don't want to do any of that. We want to live our life. So that's market forces. And so that's what you'll naturally get. So the less knowledge and skill you have, you'll get less patient retention. That's what'll happen. So what are the different business models? Well, that's the worst model. Is, the less you know, the more you're going to get market forces. And most patients will stay for symptom care, and that's typically about 6 to 8 visits. That's about it. So what are the different business models in chiropractic? Well, obviously there's the subluxation model. And I'll comment on a few of these, and then what I'll actually do is show you how to evaluate patient retention, and then how to find exactly where the problem is and how to correct it. So the problem with the subluxation model, the good news and bad news about that is most chiropractors aren't 100% in on that. There's such thing as somatovisceral reflex. Sure. Is it the cause of all Earth's ills? No. So a lot of times I found about 80% of the doctors really can't push that. They don't wholeheartedly believe it's the cause of every health problem. So that gets to be a problem. Now, the doctors have high conviction. They typically can sell it pretty good, but it's a hard model to sell. And the reason it's a hard model to sell is because patients don't even know what it is. They've never heard of the word subluxation. And it's a hell of a paradigm shift when you say, nerve pressure can affect bedwetting, asthma, allergy, cancer, digestive system, back pain, neck pain, earaches. I mean, it's pretty unbelievable. Okay. So that's why I usually, when I do a practice analysis with doctors who are doing the subluxation model, there's usually a large dropout rate. There's a lot of patients that drop out, and you could imagine going to the dentist for your tooth, him looking at your history, and he sees you have asthma, and go, "Oh, by the way, I think we can help your asthma. Your molar as meridians that's connected to your lungs. I think we might be able to help your asthma." Well, your trust and confidence would shoot down, and your defense and resistance would shoot up. And that's exactly what happens when chiropractors are talking like that to patients. So anyway, that's one model. Another model is we call it a homeopathy model. A homeopathy model is doctors, it's doctors that are really focusing on homeopathy with their practice. You don't see that a whole lot, but they're dealing with a lot more natural things and more esoteric type of therapeutic procedures. So that's kind of rare that you see just only. There's diet. So you got the subluxation model. You've got the diet. Let's see, subluxation. You've got the homeopathy. You've got nutrition. That's a model. Usually the doctors who do nutrition model, it's easy to believe in, especially if they've known it and they got higher education and they're real clear about what they're doing. It's really just how well they know how to communicate it. So you got the nutrition model. You got applied kinesiology model. That's kind of hard for some people to believe. I mean, that's a real paradigm shift. I mean, I still remember the first time I saw it in chiropractic school, when I had a patient would lay on the table with the baby and they would do surrogate testing through the baby. I'm like, oh, come on. So there's a lot to do with how the public perceives what you're doing and saying also. So sometimes that can be a really difficult, depending on how you stair step the patient into it. But I remember asking a AK practitioner one time, I said, well, what's the mechanism? How does it work? He didn't even know. I'm like, well, that was the end of that. I was out of there. So anyway, that's AK model. You've got the chiropractic biophysics model. That's a good model. That's a real solid science-based model. It's based on structure, basically getting the patient's structure back, the biomechanics of the spine. They deal more with static structure, not dynamic structure. Stationary x-rays, basically curves, cervical lordosis, etc. So real good science-based model, very focused, a lot of science behind it. I'll just a couple notes. It's expensive, takes a lot of labor, takes a lot of equipment. They got very unique equipment. It's very big. It takes a lot of labor to put people on and off. So typically a doctor who's doing biophysics has a lot of space, a lot of overhead, because they need a lot of space. They got the expensive equipment. It takes a lot of labor to put people on and off. I went into a chiropractic biophysics the other day. They had 4 employees just putting people on and off. I'm like, boy, I would want, and they're over 3,000 square feet. And they have these huge machines that take up a ton of space that are unique, that cost a significant amount of money. I'm like, I would want nothing to do with that. But clinically, it's real sound. But from a financial business model, boy, there's a whole lot of other business models that make a lot more profit than that. So that's a little bit about, there's the functional capacity model, and that has to do with just the patient's ranges of motion, bending, moving, etc., functional capacity, and how they move. So that's a particular model. These are some of the most common ones. And of course, the model we use that I like, that everything's based on, whether you like it or not, is the science of the 3 phases of healing. So I don't have to make anything up. So that's why I like the patient education. There's no paradigm shift. It makes sense to the patient. It's clinically sound. In other words, their care is totally based on the science of the three phases of healing relative to the patient's biomarkers. So I found that to be the best model, the easiest to communicate, the most effective, and the easiest to get conviction and believe it. So the goal of basically how that works is the goal of the inflammation phase is to decrease pain, inflammation, and muscle spasms. So there will be certain tests, symptom test, subjective test, hybrid test, or objective test that will show there's inflammation. So we'll do anti-inflammatory therapies and we'll quantify it and evaluate it through the progression of care. It's very straightforward, all science-based, very straightforward. And it's totally based on the physiology, the true physiology of how we heal. So that takes us to the repair phase, the second phase of healing. And the goal there is to increase active, passive, and joint range of motion. There's all three ranges of motion, not just active range of motion. And what happens with the tissue neurologically, the nerves can get trapped in the new type 3 collagen coming in, the scar tissue coming in. The nerves can get trapped. The nerves have hypersensitivity, and there's an increase in the number of nerves. And the inflammation itself, the difference in the pH of the tissue will cause pain. So these are some of the most common causes of pain. And so we're using the proper therapeutics. It could be, there's a lot of vehicles to decrease pain or inflammation. The chiropractic adjustment helps with pain, helps with inflammation. A lot of people are using, whether it's shockwave therapy or cold laser therapy or muscle stim. There's different mechanisms of action of how cold packs. So again, it just depends on your preference. We always like to use the therapies that work the best, that cost the least, that take the least amount of labor and space. That's just kind of common sense to me. So we don't just stack up on expensive therapies. So that's what happens with the collagen or with the nerves. And then the collagen is not as type 3 collagen is only 70% is strong and only 70% is elastic, which takes us to the remodel phase. So the goal of the remodel phase is to affect the type 3 collagen with physical medicine. So we use active rehab and chiropractic typically. And there's all kinds of active rehabs, from exercises, resistance to therabands to pinnacle tractions to the theraballs. So again, it depends on what you're trying to accomplish, and then you can look at what the therapies cost, how much space do they take, how much labor do they take, how much reimbursement do you get. See, all of these are factors you want to pay attention to when you make a decision on what business model you're going to use for patient education. But that's why we use patient education, because we can pretty much have a therapy suite for only $150 per unit. And you always need at least a minimum of 3 units to see over 120 visits a week. So nobody's waiting. You never have just one unit in an office, because you're guaranteed that somebody else is going to wait. As soon as that happens, you just killed the growth of your practice. That's one of the major factors that limits practice growth, is people waiting. So, okay. So that's why we use specifically the science of the 3 phases of healing. It's science. It's all science-based. There's no philosophy. It can be quantified and measured. All the biomarkers can be quantified and measured. Meaning, are they getting better, worse, staying the same, or is the patient going to end up with a permanent problem to some degree the rest of their life? And it's easy to explain. And from a professional standpoint, it's real easy to explain in the notes, medical reports, narrative reports, depositions, or trial testimony. to other professionals, medical providers, attorneys. See, it all makes sense. It's easy to explain. So that's a lot of the reasons why. So typically, unfortunately, when most doctors come out of school, they've heard of the 3 phases of healing, but they really don't. They couldn't even explain it. So I usually, when I have trained doctors, I have to increase their conviction because they usually don't even know it. They don't even know the 3 phases of healing well enough to explain it to somebody. So, but it's really solid in as far as treating. So those are some of the business models. So the very first thing you have to do is you got to pick a business model. And you don't want to just mix and match, and you don't just want to wing it. Now, some people have perfected their business model really well. Like me, we're really good with our patient education and getting the patient. We'll have, as much as 70, 80% of our patients accept all 3 phases of care. And they'll go, and it's not just symptom care. They'll go, yeah, that makes sense. And by the way, when you explain it, it does make sense. And then we just make it affordable to them. That's it. So the very first thing you want to do is have a model you believe in, or you can easily believe in. Number one, I remember I was dealing with a chiropractor one time. I said, "What's your your average recommended visits?" He says 24. I said, "Why is it 24?" He goes, "I don't know. I just kind of like that number." Well, obviously that doctor wasn't doing well. There's absolutely no conviction behind what he's doing. So there's got to be a real solid reason why you do what you do, or you'll never be really good at it. So, and you can't just treat the patient and expect them to stick around. There's got to be reasons why they're sticking around. Okay, so we covered a lot of the business models. So the very first thing you want to do is pick a model that is in line with, who you are. That's the best way. Like, and I was that way with subluxations. I'm like, yeah, there's a somatovisceral reflex, but no, it's not responsible for every ailment to mankind. And I'm not gonna promote it like that, because I'd be lying. I couldn't do it because to me it would be untruthful. There's nutrition only problems, there's mental emotional problems. I've treated a lot of patients, and I've had the BJ Palmer experience where I treated a patient who had no smell and the smell came back. Okay, so I'm quite aware of a somatovisceral reflex, but I've treated patients who got better with asthma. And I remember one of the first patients I treated, she was a 13-year-old girl who lost her cycle. And within a couple of adjustments, she got her menstrual cycle back. That's pretty important for a 13-year-old girl. So I'm quite aware of it, but I've treated hundreds of patients who had high blood pressure and asthma and digestive systems, all kinds of other problems, who didn't get better. Matter of fact, more of them did not get better with organic problems than did with chiropractic. And I'm just telling you from my experience. Okay. So you have to find what business model. Unfortunately, it's not readily available in chiropractic. It's not like chiropractic school says, okay, here's the different business models and here's how to communicate them. They don't really do that. So you kind of got to figure it out on your own, or you got to go somebody that knows it, or you got to do trial and error stuff like that, unfortunately. And so that's what happened with me. I did kind of trial and error, and then I ran across the 3 phases of healing. I'm like, man, that's what all care is based on anyway, because if it's not based on that, it's fraud. That's how we heal. Okay. So that was pretty easy to come to that decision. Real straightforward, science-based. That's what it should be based on. And if you're billing third-party insurance providers, that's what it better be based on. Okay. So let's go to number 2 is conviction. So conviction happens in 2 ways. It either happens because you have a major traumatic experience that affects your survival or security. That'll increase conviction. Or it happens over time. So you'll see some doctors like me, my conviction in chiropractic happened fast. When I was 15 years old, I injured myself, my tailbone. I couldn't sit down. It affected my activities of daily living. So for 3 months, I was sitting on an inner tube, taking medication, didn't help. I finally went to a chiropractor. This is a classic chiropractic story. Finally went to a chiropractor, and in 3 adjustments, I was 100% normal. So you couldn't tell me, and you never could tell me chiropractic doesn't work, because I had a high personal emotional experience, conviction with it, fast. Now, most people don't have that. And so it has to be taught in, conviction has to be taught in. And so a lot of times when I'm training doctors, in other words, it's over time. So I would have the doctors learn the 3 phases of healing and all the major points, and then we would apply it to the patients when they would come in and train. I go, okay, let's look at the mile markers. Let's do the therapy based on these mile markers in the inflammation phase. We'd quantify it, treat the patient with the necessary therapeutics for those biomarkers. We'd treat them for a period of time, reevaluate them. Then we'd look at the biomarkers for the second phase of healing, active, passive, and joint motion. Then we'd apply the appropriate therapeutics for that and quantify it. You always have to quantify it to see if it's getting better, worse, staying the same. And then as that progressed, we went, okay, now we're ready for rehabilitation. Why? Because type 3 collagen's not as strong and it's not as elastic. So then we had to do the therapeutic protocol to increase the strength and the elasticity. See, so I not only had them learn it, but they actually saw it live as the patients came through. That significantly, and it took about, I'd say about, definitely 90 days. I thought when I had doctors come through and see that whole experience, within 90 days, they're like, no, we get it. 3 phases of healing, we get it, we understand it, and then I would teach them how to communicate it, to easily communicate it to the patient. Well, that's what increases the conviction. And usually when you increase your conviction, you'll naturally, as a byproduct, increase your confrontation. Now, so that's a whole nother animal when it comes to training, is how to help doctors overcome their fear of money. There's a lot of doctors that don't want to talk money. Matter of fact, they're even afraid to try to do prepays. And getting the patient to accept the treatment plan and sign off on it or pay in full significantly reduces them from dropping out from care when they feel a little better. So a lot of doctors won't do that because they got low confrontation or low conviction, but you can still have high conviction and low confrontation and be afraid to talk money and not be willing to offer prepaid treatment plans. So, training for confrontation is another issue. Okay, but that's essentially what patient retention is based on. And then there's 3 types of patient retention. We already talked about the inflammation phase, the remodel phase, the inflammation phase. And then there's what's called the functional capacity stage. Well, that's that's essentially when you're dealing with one of these models, whether it's the 3 phases of healing, chiropractic biophysics, homeopathic, acupuncture, whatever the model is, and then to take care of that problem. And then there's what's called the lifestyle or maintenance care. And those 2 are different. Maintenance care is when somebody just gets periodic care. And, chiropractors, and, they try to sell maintenance care, but it doesn't work very well. 97% of the population does not accept maintenance care. So I never recommend maintenance care. I always recommend lifestyle care. Lifestyle care is very specific. There's a specific goal, there's specific biomarkers, and there's specific treatment. In no way is it maintenance care. And so when you have a specific goal, you have specific guidelines, you have specific biomarkers and specific checkpoints. That's what keeps people more disciplined and on their treatment plan, not come back once a month for maintenance care. That's why that doesn't work well at all. Okay, so having said that, I'm mainly referring right now to essentially the second phase of patient care, which is the functional capacity component, whether you're doing biophysics, science of the 3 phases of healing, whatever it is, okay? So let's go ahead and take a look, because you always have to get good at that first before you try to do anything with lifestyle care. So so the less effective you are at communicating that functional care, the more you get market forces. What does that mean? It means the patients leave early. So let me show you this chart, that how to keep track of the statistics. And what it's going to show you is when you keep these statistics and you know how to evaluate these statistics, essentially it's going to show you how to increase your business $100,000 in 90 days, essentially what it's going to do. But what it's going to do is it's going to show your strengths and weaknesses with patient education. It won't be your opinion. Now, if you do the statistics correctly, they'll be correct. If you don't lie on them, fudge them, meaning like a lot of chiropractors will fudge on statistics. And a classic example, and I hear this all the time when I talk about statistics, chiropractor will say, well, that patient only came in once because they don't live here and they're a truck driver and they just stopped by. I'm like, yeah, okay, I've heard that 1,000 times. Guess what chiropractic office doesn't have that? So you always keep all statistics. You never cherry pick, whether it's that person or the person that I just, for whatever reason, stays with you for life. See, you got both ends of the spectrum. So you keep all statistics. You can come in later and segment out, okay? But you keep all statistics to see where you're at. And matter of fact, the hardest statistic, if you really want to check how good you are with patient education, is to only evaluate your cash patients, your cold call cash patients that come in with a discount coupon. That's the most difficult patient to keep. So if you really want to check your skill level. Now, the easiest patient that doesn't take much skill level at all is the personal injury patient or the workers' compensation patient. And the reason, and it's really, personal injury is easier because it's paid for. They don't have to pay anything, and they're essentially going to get rewarded for coming in for care because they're going to get an injury award, and they kind of know the injury award is going to be based on making sure they get care. So that's the easiest. I actually had a doctor, he thought he had great patient retention. So we checked his, he had no problem with personal injury. So then we checked his non-personal injury patients. He lost every one of them by the 6th visit. See, he thought he was okay because his personal injury patients stayed with him. No, they weren't paying and they were rewarded, but for coming in. That's a whole different animal. And then the extreme to that is the cash patient who comes in with a coupon. So you got a discount mentality, and it's a cold call. There's no trust. They don't know you. You don't know them. That's the most difficult patient. That's the real test. If you only want to segment that out to see how your skill level is. Okay. So having said that, let's go through and let's take a look at the document here on how to evaluate it. So let's take a look at this. And essentially what we're looking at is a Excel spreadsheet. So this is one way to look at it. Matter of fact, let me just show, I think this other one that I have is easier to see. So let me show you this one here. That's this one right here. Okay. Okay, I think that one's just going to be easier to see. So let's just pay attention to that one. Okay, so here's essentially what we're doing is we're trying to evaluate when we're losing patients. And when we find out when we're losing them, if we know how to interpret the statistic, then we know why. Because you always have to find the problem first before you act on it, before you go to a solution. And that's another problem. I typically see doctors just try to run to a solution and they haven't even found the problem. And because they typically don't know how. They don't know how to keep stats. They don't know how to interpret stats. So that's what this is about, is learning how to keep and interpret. So this is for patient retention, okay? So here's what you do. We want to evaluate at least 50 new patients. You can do 30, but you don't want a small sample size. In other words, I wouldn't want a sample size of 3. That's not going to be very accurate. And you could do 30, but 50 is pretty solid, okay? So we want to evaluate 50 new patients for the drop. Now, how we do that is you have to go backwards 30 days first, okay? You can't start in the first 30 days because let's say that you let's say it turns out you have a huge dropout on the 5th visit. Well, if you're taking patients, if you're including patients in the first 30 days, they wouldn't even have dropped out yet. Or let's say they dropped out on the 10th visit. A lot of them wouldn't even have dropped out at because you didn't even give them the chance. So do not include the last 30 days or you'll have a fake statistic. Okay. So go back at least 30 days, and that's the starting point. And then from that point going backwards, list your last 50 new patients. And don't cheat. List them on there. That's how you're going to find real problems. And you won't be able to solve problems unless you know real problems. So you really want to, it takes a little humility because you're looking for weaknesses. But that's how you grow a practice, is by looking for weaknesses, not strengths. You're typically not going to have growth problems because of a strength. You're typically going to have limited growth problems because of weaknesses. So you always have to be looking for the weakest link and solving it. And that's what always will increase the growth of a practice. Okay. So on the left-hand column here, where it says patient's name, we'll just write all 50 down vertically. There's the last 50 new patients after 30 days. Then when you see at the top here, it says 1 through 20. Now that's going to represent patient visits 1 through 20. And what we want to do, and 1 through 20 is fine, because remember, this won't measure lifestyle care, but it'll definitely measure symptom care and the functional capacity. In other words, what model you're using, okay? And that's where most doctors have the problem anyway. Okay, if you're good at lifestyle care, that means you're really good at functional capacity care. Okay, so here's what happens. You just mark an X right where the last day you saw the patient. So like in the first slot here, if the last day I saw the patient was day 4, I'd mark an X there. If the last day I saw the patient was day 12, I'd mark an X there. And I do that for every one of these patients. Now, if the patient is still coming in, there should be no X. The X represents the last day you saw the patient. Okay, so that's how you collect the data. Now, how do you interpret it? Well, you come down to the bottom and you add up. Come down to day 1. Add up day 1. How many in day 1 did you lose? And then look at it from a percentage standpoint. So if you had 50 people and you lost 5, that's 10%. You lost 10%. 5 out of 50 is 10%. Okay? So do the same thing with day 2. Now, when you do day 2, let's say that it's not going to be 50 anymore. So let's say you lost 50, you lost 5 on day 1. Well, now on day 2, you're only dealing with 45. You see? You're dealing with a smaller number. So when you, on day 2, add up the number that you've lost on day 2, and let's say that number is 5.2. Well, that number is going to be greater than 10% because you're dealing with less than 50. You're dealing with 45. So you want to know the total dropout, and then what is the percentage of dropout? And we want to do this for all 20. We want to add up every column at the bottom here. Add the total number, and then what percentage is that? And then what you do, so now we've collected the data. Now let's go into how to interpret it. Now we want to look at the bottom and go, well, which day is the biggest day that you're losing patients? So there's typically 4 areas where doctors lose patients. Now, the good news about this, there's really only 4 areas we're going to lose patients. So, and 4 different reasons why you'll lose patients. So it's pretty easy to find out. Now, most doctors do what's called a report of findings on day 2. That's kind of typical in the chiropractic industry. So what we'll do is we'll add up the total number, and then we want to look at what day they're losing the most. So let me share with you how to interpret that now. Remember I said there's 4 typical days when you'll lose patients. Day 1 is a common day. There's a lot of doctors that lose a lot of patients on day one. Now, what's the number one reason that you'll lose patients on day one? You have an established need. In other words, they had enough need to get in their car and come to your office and spend the time or money to come to your office. But they didn't come back on day two. You didn't establish need. The number one problem, overwhelmingly, why a patient does not come back on after day one is you didn't establish need. And there's a way to do that. There's a way to do that. Now, a secondary problem that I do see, and it's mainly with subluxation practices, is a paradigm shift. And the example is like what I gave you before. You go to the dentist for a tooth problem. You sit in the chair. He looks at your history and he says, oh, I see you have asthma. I think we'll be able to help you with your asthma because there's meridians that go from the molar to your lungs. Chances are you're not going to come back to that dentist. You're going to think he's a little kooky and weird, and you don't even want him dealing with your teeth. That's what happens with chiropractic and the subluxation model. But chiropractors don't realize that because to them it's normal. They've spent every day for 3.5 years talking about this thing or hearing about this thing called subluxation. So for them, they think it's totally normal. Well, it's not normal that somebody thinks you can adjust their neck and help them get over cancer. That's not normal in the real world. That's called a huge paradigm shift is what that's called. And by the way, the example that I just shared with you, the meridians and the molars affecting asthma, that is true. That's a true meridian chart. Okay, so number one is what's the most common reason? So the most common reason is not establishing. Number two is a paradigm shift. And the most common is, like I just shared with you, they come in for back or neck pain, and you talk about the subluxations and how you can help with asthma, allergy, and bedwetting. You push to that, you point to the old chart that shows the nerves going to the lungs and the kidney and the heart. Okay, that's a common area. Number two is the report of findings. Now, the only place you should lose patients is where the obstacles of time or money go up. That's the only place you should lose patients, is when the obstacles of time or money go up. And that's only about 3%. That's it. So we're going to go ahead and take a look at that and go, okay, if you were going to lose a patient, you would lose them at a point of where they spend money. So day one, they spend money, report of findings, they spend money. So you can expect about a 3 to 4%, around a 3% loss there. That's if you know what you're doing and you're good, you'll still lose about 3% in that area. So we're at the day two in a typical report of findings. Now, that's a common area where doctors will lose patients. That's the second most common area. The number one reason you'll lose patients on day after you report of findings is you did not make it affordable to them. So you see, it's a ratio. When patients buy, it's a ratio of how much perceived need they have relative to the money and time they're going to spend. That's the core of the ratio right there. So if their perceived need is higher than their perception of money, just like you'll buy. If you're going to buy something and you think you'd okay and pay $10 and you find out it's $5, you go, oh yeah, you'll buy that. But in your mind, if you think it would be $10, but it's $100 and your perceived need is lower, you won't buy it. Okay. So no different with patients. It's the ratio of their perceived need relative to how much money and time they're going to spend. So the most common reason they're going to drop out on day four, they have a need, or day two. They had a need to come to day one. They had a need to come to day two. So the need is there to some degree. So usually it's the doctor not handling money right, not delivering terms right, not communicating terms right. Now, I will say it's never a standalone. It's never like just one problem and only one problem, period. It doesn't work like that. It's always a preponderance of an issue. So like on day one, the preponderance is not establishing need. Well, is money and time and trust still a factor? Yeah, but it's not the preponderance, typically. Is on day two in the report of findings, the preponderance is money, typically, because they've already showed enough need to come in for day two. Okay. So we're going to pay attention to the preponderance and not chase everything. Okay. Now, the third place that you typically will lose them is around the 8th to 12th visit. That's real common. So we'll see a lot of X's around the 8th to 12th visit. And the reason they're leaving there is they didn't buy into your model. Whatever it is you're doing with patient education, they did not buy into it unless your model is symptom care, because that's why they're leaving. They're feeling better and they leave. There's no reason for them to stay. They have not bought in to whatever it is you're trying to educate them. They have not accepted it, have not bought in. That's the number one reason right there. That happens a lot. Then you come over to what's the fourth place patients will typically leave. It's actually really in the early 20 visits, like around 22, 24. Now, we don't have it on this chart on purpose because if you're keeping patients up to 20, 22 plus visits, you're going to have a pretty good practice to begin with. Chances are you're seeing well over 100 patient visits a week. So we're not going to pay as much attention to that. But if you are, if the dropout, in others, let's say your patient retention in the functional capacity area is good, and then we'll go ahead and evaluate the lifestyle statistics over 20. Well, if it's under 20, they bought into the functional capacity, but they didn't buy into your lifestyle if they're leaving in the early 20 visits. See, this is how you interpret these statistics. Okay, so this is what we do first, and then we find the greatest weakness. Well, the greatest weakness is the patients you're losing the most. Now, there's good and bad news about this. If you already know the model that you're, like I already know the model of the science of the three phases in. So I already know what should happen on day one, day two, day three, day four, okay? Not only should I know horizontally, but vertically what should happen. In other words, I should know what major topics should happen on day one, day two, day three. You get the point. We already know that. That's not an accident. Okay. Now, when they come in on day one, there's very specific things that need to be done on day one. What should happen first? What should happen second? What should happen third? See, all of this is already well known. It's called reverse engineering. And it's based on the patient's natural purchase cycle, how they think consciously and subconsciously. It's never based on the doctor's opinion. So you actually have to learn the purchase cycle of a patient. And then you apply that to keep patients. That's called reverse engineering. That's why our systems work so well. None of it's based on chiropractic. It's all based on how we buy products and services consciously and subconsciously. What do we want on day one versus day two versus day three? And on a particular day, what do I want first, second, third, fourth, or fifth? See? Well, the more you have that, the more you know that, and the more you know how to deliver it, the better your patient retention is going to be. That's the bottom line. So the good and bad news about this chart is we can find the major problem. Is it day one? Is it day two? So we already have an idea of what the problem is. Like if it's day two, it's typically terms. If it's day one, it's not establishing need. If it's, most of the patients are a cluster between 8th and 12th visit, we know it's symptom care. Okay. All right. But here's what we don't know unless you're actually recording your interaction with the patient. Let's say in each of these days, day one and day two and day three, there were 10 specific topics. Well, let's just say 5. Let's say there were 5 specific topics the patient wanted to know and the order they wanted to know them. Okay. Well, we won't know if you don't record that session. We won't know if you covered topic 1, 2, 3, 4, 5. So we'll just be guessing. But the great news is when you keep these statistics, we'll not only know the day, so immediately we're not chasing everything. We know exactly where to go, and we already have an idea of what the problem is. But when the doctor actually records as an audio recording of the patient, we can listen to the recording, and we know if X, there should be 1, 2, 3, 4, and 5, and we listen to the recording, and we go, well, he didn't even cover 3. We know what the problem is. Now we know why the patient did not come back after day 1. That was the majority of the day that was missing. So we go there from the stat. Then we have to go to the recording. Otherwise, we won't know which of those categories of that day was not done well, messed up, or not even handled. Now, if you don't know the problem, it's going to take you a hell of a lot longer to come up with the solution. So the very first thing you always have to do is drill down really deep and specific to find the exact problem and not guess. That's the first thing to solving a problem. So as an example, when I do this with a client, I'll look at the statistic to see how well he's keeping patients. And then I'll go to the highest number, and then we'll have him do an audio recording of the interaction with the patient. And that'll tell us exactly what he's missing or not doing on that particular day. Then we know how to train it out. Then we role play it and train it out to where that doctor corrects that problem real fast. And then he no longer has that problem. So that no longer becomes the weakest link. So like in this example, that's how we would have found the problem. So in this example, it would be, say, day 1, and it was the third category of 1 through 5 that he was not handling right. So then we go, okay, let's train it in. We'll do a lot of role playing with that topic, so the doctor's really good at it. And then we'll put him back in the room, and then that's how he'll overcome it. That won't be a problem anymore. And we'll see day 1 dropout significantly reduce. It'll stop essentially. This is how you stop problems. Now, as soon as that happens, what happens to the practice? It goes up. What's the next thing we do? We do the exact process all over again. Excuse me, all over again. Now we go for where's the second place that they're dropping out? Let's say it's day 2. Okay, let's go to day 2. Now, do we have a recording of day 2? When we don't have a recording, we won't know the problem. We have a recording, and now we know on day 2, let's say there's 7 things that should have happened in order on day 2 based on reverse engineering, okay? And we listen to the tape on day 2, and we go, well, he didn't even cover 5 or 6, or he didn't even cover well at all. See, now I know day 2's the problem with the dropout from the statistics, and I know category 5 and 6 is the problem from the recording. Now I know how to train. So now I'm going to take that doctor. I'm going to make sure he understands what should have happened. First, he's got to see what he did wrong. That's the very first thing you have to see. What'd you do wrong, and why was it wrong? Because if you don't see that, you'll just keep doing it over. Once he sees it, then we go, okay, let's train it in. Let's clean it up. So we'll do a lot of role playing with that particular topic, whatever it is, to get it to muscle memory as fast as possible. Then we'll put them back into the rooms with the patient, get going again. And let's say that communication has been cleaned up. 5 and 6 has been cleaned up. That takes care of day 2. He no longer has a significant dropout problem in day 2. What just happened to the practice again? It goes up again. Let's do it again. We go, okay, let's look, he's losing patients between day 8 and 12. Now, the bad news about this, if you're losing patients doing 8 and 12, it usually indicates that you have a bad system. It says they're not accepting your patient education. Whatever business model you're using, they're not accepting it. That's what it says. So usually you got to change your business model. Now, usually when that happens, doctors don't have a clean business model. they're usually, when I talk to them, they go, it's haphazard. They did a little of this, little of this, little of that kind of thing. So usually when that happens, I just tell the doctor, you got a crappy business model. You got to change your business model. They're not even buying into your business model. So, and then that's typically when doctors go into the business model of patient education, 3 phases of healing, because it makes sense. It's easy to communicate, makes sense. So that's what we do there. So typically it's a business model problem, not a specific day. They just didn't believe what you said. They didn't accept what you had to say. That's the fast way. I just shared with you the fastest way to increase your business over $100,000 in 90 days. Let's face it, it's a lot easier to keep business than it is to try to go out and get it. It's much harder to try to go out and get new patients than it is to keep your existing patients. Much harder. And it's much more expensive with time and money, knowledge and energy and skill. So the very first thing you always want to learn is patient retention, because if you don't, every other statistic is bad. The number of new patients you need significantly goes up. Your time and money you spend on advertising goes up. Your quality of new patients now goes down. Your overhead goes up. Your profit margin goes down. Everything gets difficult exponentially when you lose patients. And how you know that is you have to do the dropout analysis to see. And then you go, well, how many patients are prepaying? So we'll pay attention to that too, because generally speaking, when they prepay, whether they prepay all at once or they agree and sign off to a biweekly or a monthly payment plan, that will significantly reduce whatever business model you're using, the dropout rate. So we'll look at the dropout rate plus the prepay percentage. And then one thing we won't pay attention to as much is your patient visit retention. And the reason we won't, and your patient visit, even though you want to know the number, you don't want to pay as much attention to it because it's a little bit of a fake number. Patient visit retention is the number, you take your total patient visits divided by your number of new patients over the same time period. That gives you your patient retention, an average number of visits. But the reason it's not a totally true number is it's including reactivations, maintenance care. So it's padding the numbers fake. It's giving more visits than really what the doctor's getting. So that's why we will not base it on patient visit retention. We'll base our patient retention on dropout analysis. That's what'll tell us the skill level, the amount of skill level, the lack of skill level, the degree of skill level, exactly where the problem is, and exactly what to do to fix it. It's the fastest, easiest problem to fix when you keep your stats, and then you know what should happen on day 1, 2, 3, 4, etc. And then each day you know what should happen from reverse engineering, not an opinion, from reverse engineering the consumer purchase habits. And that's what our patient education system is. That's why it works so well. And doctors increase their business typically $100,000, $150,000 within 90 days. They immediately just start keeping patients. That's what happens. So patient retention, unbelievable, huge, huge topic. And everything in the chiropractic practice starts with patient retention. And then you go, okay, what business model? Where's your conviction? Where's your confrontation? And how well were you trained communicating and delivering that information, not just horizontally, what the patient wants and expects day to day, but on each individual day vertically. Believe it or not, patients actually expect certain things in a certain order on day 1, 2, 3, 4, 5, etc. And the more your patient education is geared to that, in other words, you're delivering on day 1 what they expect. You're consciously and subconsciously. You're delivering the topics in the order that they expect them. And a real simple analogy, and I'll just use a simple analogy, is the four big questions patients want answered is what's my problem? And they want them answered in this order. What's my problem? Can you help? How long is it going to take to feel better? How much is it going to cost? That's the order that they want it answered. Now, there's a lot of other topics they want also within that, but that's the four big ones. You mess those up, you're going to lose the patient. So this is how we analyze, find, and solve problems and increase chiropractors' practices over $100,000 typically in 90 days.